Hi, good evening, everyone.
Good evening, good evening.
Good evening, sir.
Ma'am, how are you?
Sir.
Good, very good. Thank you. I'll be leaving after some time because I'm in Jaipur. So I'll be only at the beginning and then you take over. Dr.
Ma'am, we are live.
So welcome everybody to this webinar today. And we have restarted this series on popular demand. And this series is walk-in patients. So if a walk-in patient is there, especially with the retina pathology, we're going to discuss retina pathology today, then how do you diagnose, treat, and when do you refer the patient? We will be joined for a brief period of time by our chairman, Dr. Lalit Verma, who's the president of All India Ophthalmological Society and director of Retina Services at Center for Sight, New Delhi. I have with me my co-moderator, Dr. Rajiv Jain, who's the principal vitreoretina and uveitis specialist and surgeon at Safe Sight Center, Delhi. We have a galaxy of speakers with us today who will be talking about important topics. Dr. Shishir Varghese, Managing Director and Consultant Vitreoretinal Surgeon, Eye Microsurgery and Laser Center, Tiruvalla, would be talking about walk-in patient with diabetic macular edema. Dr. Vipin Rana, who is the head of the Retina, Uvea and ROP services at Command Hospital, Kolkata, would be taking us through the ROP screening and management. Professor Wing Commander Avdesh Oli, vitreoretina surgeon, again, Command Hospital, Air Force from Bangalore, would be talking about new techniques for management of aphakia. And Dr. Ankur Singh, Assistant Professor, Vitreoretina Department, Department of Ophthalmology, University College of Medical Sciences and GTP Hospital, New Delhi, who's also a student of ours and an RP Center alumnus, will be talking about OCT angiography, basic concepts and its advantages in clinical practice. So I would request Dr. Rajiv to please take over and start the webinar. So Dr. Rajiv, you have to unmute yourself. You're muted. Yeah.
Hello, everyone. Good evening. So, ma'am, I guess we have all the speakers with us here now.
Yes, they are. Everybody is there.
So, shall we start with Dr. Varghese now, or someone else wants to come in?
Dr. Shishir Varghese, I think, will speak and give his talk first. Dr. Shishir?
Yes, ma'am. I'll share the screen.
Yeah. Thank you, Dr. Shishir.
Yeah, I guess it's visible to everybody.
Yes.
Yeah. Okay. So thank you, AIOS, and also Allergan for giving me this opportunity to present my talk on diabetic macular edema. So it's basically meant for all comprehensive ophthalmologists as well as PGs who will probably benefit from this talk. So no financial interest. So just a brief on the introduction. So diabetic macular edema can exist with any level of diabetic retinopathy, be it moderate NPDR, severe, or even PDR. And we know that it's due to multiple pathways, especially VEGF, and it could be inflammation mediated, as well as we can have tractional elements to it. So multiple previous incidence-based studies have been done, which show that type 1 and type 2 DM can both have a presence of macular edema in various percentages. So the DCCT was a landmark study which showed that 27% of type 1 DM developed diabetic edema within 9 years of onset. So what exactly is DME? To define it, it's nothing but retinal edema threatening or involving the fovea due to diabetes and leading to vision loss. So it's the leakage from the solitary microaneurysm, or it's a leakage from the hyperpermeable capillaries, which cause the fluid to accumulate in between the retinal layers. So coming to an update in the DME definition and terminology. So earlier, before the era of OCT, we used to define it based on the clinical exam, which was a retinal thickening within 2 dd of the macular center. After, in the era of FFA, it was defined as focal, diffused, or with mixed edema. But now we have OCT, and we are doing less of FFAs for DME. So based on the OCT, we are defining as center involving DME and non-center involving DME. So this was the earlier definition, CSME, which most clinicians still use it today. Retinal thickening within 500 microns of the fovea, hard exudates within 500 microns with adjacent retinal thickening, and retinal thickening of at least one disc area in size, any part of which lies within one disc diameter of the center of the macula. So to give some examples of this, when you see clinically with the stereoscopic 90D examination, you see retinal thickening within 500 microns of the fovea, which appears slightly shallow, elevated, little bit of a off-color patch. Then you can have retinal thickening, hard exudates within 500 microns, but with an adjacent retinal thickening. And the third one, which is retinal thickening of one disc diameter, any part of which lies within one disc diameter of the fovea. So this was a clinical examination definition. Now, based on the FFA, we can have a diffuse maculopathy. What you see in the first picture there, in a patient with a proliferative diabetic retinopathy. And in the second picture, what you can see is like a focal small leakage in the the mid phase of the FFA. So now we have OCT, and based on the OCT, we can define it as non-center involving DME, which is basically less than 305 in women and less than 315 in men. So this is basically the new definition and guidelines published in the IJO. So this was the new definition of a non-center involving DME. So here the center thickness is normal, but the subfield thickness is increased. So when you look at your OCT maps, you can see that the center is actually normal, but there's an increased thickness of the subfield. So that's basically non-center involving DME. So the next one is center involving DME, where the foveal center is involved, and anything more than 305 or worse in women and 315 or worse in men is center involving DME. And when you take the OCT map, you can see the center is 465 in this patient, which is basically edema of the foveal center. So there are various other classifications. I'll just show some pictures. I won't touch upon it in detail. We have spongy thickening. We can have cystoid edema, that is presence of these large cystoid spaces. We can have cystoid edema with subfoveal detachment, and as well as spongy thickening with subfoveal detachment. You can also have skytic edema. Skytic is basically the elongation of the cystoid spaces due to the chronicity of the diabetic edema or long-standing untreated diabetic edema. And we can also have some tractional elements to it, like in this second picture, we can see skytic edema with the presence of an epiretinal membrane. So, as I said, epiretinal membrane, you have to rule out mechanical causes of diabetic edema because then the treatment is totally different. So in this patient with a proliferative diabetic retinopathy, he's got a vitromacular traction due to a taut hyaloid, which is causing edema. So this is the pre-op photo, and this is actually post-op. Such patients won't improve with anti-VEGF or laser. You'll have to do surgery to relieve the traction and resolve the edema. Now I'll jump straight to DME management. So can be treated with anti-VEGF, as we all know, is now the mainstay of treatment. Steroids and as well as laser, which was the mainstay of treatment before the era of anti-VEGF. So multiple studies have been done. Ranibizumab was studied in the RIDE and RISE, as well as bevacizumab was studied in the BOLT, aflibercept, VIVID and VISTA, and steroids like Ozurdex was also studied in the MEAD study, and also triamcinolone was also studied in the protocol I. So we have a lot of options of treatment and how each of them act. So laser, like focal or grid, what it does is it causes the RP to pump out the fluid due to the thermal coagulation. And how anti-VEGF helps is it reduces the VEGF load, thereby reducing the diabetic macular edema. Steroids act through the inflammatory pathway and thereby reduce the edema. And vitrectomy is helpful, especially when there is traction, to relieve the tractional components. So always a systemic control, it remains the hallmark for prevention and progression of DME. It's extremely important to talk to the patient, tell them to get their get a good systemic control. And also renal assessment is extremely important because it's edema can be seen in patients with kidney disease. Anemia correction is generally important because those who are anemic exaggeration of the retinopathy per se. And if the patient is on glitazones, rosiglitazone, pioglitazone, these drugs exacerbate the macular edema and need to be stopped after talking to the physician. So coming to the treatment guidelines, non-center involving DME. So when you have non-center involving DME, you have, and if the vision is more than 6/9, you can probably just observe the patient and follow them up. But if the vision is less than 6/9, you can treat them with focal laser. You can probably do a focal laser to the microaneurysm, or if the edema is quite significant, you can go in for an anti-VEGF. Treat the patient with anti-VEGF and then followed by focal laser. So the progression to center involving DME is 14% at 1 year. And along with this treatment or follow-up, you have to emphasize the importance of a good systemic control of hyperglycemia, hypertension, as well as hyperlipidemia. And then the second one is non-center involving DME after the treatment for center involving DME. And in such patients, again, vision is your guide. If vision is more than 6/9, you can just observe and follow up on a 2-monthly basis. If vision is less than 6/9, you can treat them with either anti-VEGF or a focal laser, depending on the amount of edema which you see. So this is an example of a patient, 58-year-old male, best corrected vision was 6/6, had some non-center involving DME. He was followed up because vision was good, but then he started developing these few small cystoid spaces. And then eventually it became center involving, where you can see, and there's a drop in vision. And he was given anti-VEGF 2 doses. And following those 2 doses, he has been stable with vision back to 6/6 and resolution of the center as well as the subfield thickness. So coming to focal and grid laser. So we still do, some clinicians still do focal and grid laser. I do. So if I spot a microaneurysm either on the FFA or on the OCT, we can do a direct focal laser to the microaneurysm, or you can do a modified grid or a grid C-shaped grid laser. And previously it has also been shown that grid or focal laser does help in reducing the edema per se. So this is the pre and post 6-month picture of a patient who underwent focal laser to a central microaneurysm here. And then this is after 6 months, you can show the complete resolution of the edema. Focal laser, you have to vary. I mean, especially grid laser, you have to be really careful in patients who present with these hard exudates, which are close to the fovea. And when we go and do focal laser, there is a high chance the hard exudates can migrate into the foveal center and cause a drop in vision. So what are the signs of a poor prognosis? So when we have these large subfoveal hard exudate plaques or subfoveal fibrosis or pigmentary changes at the macula, these are usually the signs of a poor prognosis. Even if you treat them with anti-VEGF or steroid, you'll have anatomical improvement, but the vision may not really improve. So coming to the center involving DME treatment guidelines, as we know, anti-VEGF is the first choice. It's the first line treatment. So the drcr.net have shown that anti-VEGFs you have to give for at least 4 to 6 months. That's a recommended thing till there is no further visual improvement in the edema or in the vision. And then following that, you can just observe and follow up the patient. If there is worsening, restart the anti-VEGF treatment. If there is no worsening on subsequent visits, you can increase the follow-up by 4 months. So treatment is deferred once vision is 6/6 or OCT has become normal. And by normal means normal contour of the fovea, reduction of the retinal thickening, and disappearance of cystoid spaces. So this is an example, 63-year-old female, 6/12 vision, center involving DME with subfoveal detachment, given 1 dose of anti-VEGF. Still, there is a small subfoveal detachment here we can see. And then after 1 more dose, 6/6 and edema has also resolved after 3 doses of anti-VEGF injection. So choice of anti-VEGFs. Nowadays, we have a lot of choices, including biosimilars, which have come in the market. We have aflibercept, we have Accentrix, brolucizumab, bevacizumab. So the protocol, multiple studies were done, which showed the importance of these anti-VEGFs and the visual gains which you could get by them. So what we know from these DRCR protocols is that anti-VEGF injection with or without macular laser is the most effective treatment. And we also know that not all the anti-VEGFs are equal. So choosing a regimen is difficult. You have to talk to the patient based on what amount he can afford, and you have to really talk to them. But you have to also tell them you need an aggressive treatment, and over the period of time, the need for injections are reduced. So you also need to know that many eyes do not respond fully to anti-VEGF therapy. Approximately 50% don't respond, and eyes with good vision with diabetic edema can be observed closely. So this was a protocol. I won't go too much into the detail. I'll just tell the results. So the protocol I studied ranibizumab and triamcinolone, and they found out that ranibizumab given along with deferred laser was the best treatment, especially in patients who had less vision, less than 6/12 vision. It was much better. But if you do a prompt laser, then the need for injections is reduced. So, but however, due to the vision improving much better in the less than 6/12 subgroup, it was deemed that anti-VEGF therapy with deferred laser is the best treatment. And this protocol, I showed it at 5 years. So which anti-VEGF is the best? Now we know that anti-VEGF is the best, but which anti-VEGF is the best? And for that, we have protocol T, which compared aflibercept, ranibizumab, and bevacizumab. And what we know from protocol T is that over 2 years, aflibercept and ranibizumab is equal in giving good visual acuity as well as causing drying on the OCT, but aflibercept is better than bevacizumab. So the conclusion from this protocol T is that if the patient is affordable to, and if you can always give him an option of treatment with aflibercept, as it causes better drying and better visual improvement as compared to bevacizumab or Avastin. So it's an example of a patient, 51-year-old, 6/18 vision, given 1 dose of ranibizumab, reduction of the CME, but not completely. And vision is now 6/12. And after 1 more dose, it's improved to 6/9. And then there's still on treatment, and vision is maintained at 6/9. So coming to which regimen to choose, monthly dosing is the best. Loading, or what about loading dose and PRN, which most of us practitioners, we follow that. And then we have the treat and extend, which is like a compromise for the monthly dosing. So again, the regimen is individualized, tailored to the patient. So you have to talk to them and ask and really explain which is best for them. So monthly dosing is that means 12 visits to your OPD in a period of 1 year. It's impractical. It's a huge economic burden. There's high risk for infection, especially when you keep injecting 12 every month. And it's a time constraint even for the patient who has to keep coming. So then next we have the loading dose PRN regimen. That is anti-VEGF injection monthly for 6 months and reassess the vision and the OCT and defer the injection if it's stable. You can also, if there is mild edema, non-center involving edema, you can even think of focal laser later or PRN-based anti-VEGF injections. So protocol I, again, anti-VEGF, studied in ranibizumab for diabetic edema. They showed that in the first year, you give maximum number of injections. Then over a period of the next and the third year, the need for anti-VEGF is actually reduced. So this also we have to tell the patients when they present to the OPD with diabetic edema that if we treat aggressively in the first year, then your need for injection reduces in the subsequent years, and it's a prolonged treatment as well as follow-up. So what about the final one? That is a treat and extend regimen. So what the treat and extend regimen, it means is that you give them 3 injections or 4 injections till there is absolute reduction of fluid, no activity, and the vision has improved to the maximum. Then after that, you can extend the follow-up as well as the treatment with 2 weeks. So that means if I have seen him for every month for the 3 months and there is no vision improvement beyond that, I can call him now after 6 weeks instead of calling him at 1 month and give an injection and then call him again after 2 months. So you are increasing the interval by every 2 weeks. So that's what the treat and extend means. So if there is in any of the follow-ups, if there is fluid, then you have to reduce the interval by 2 weeks. So the TREX DME study showed that it is equal to the monthly cohort, but you require lesser number of injections as well as the patient needs to come only for lesser number of follow-ups when we have when you follow a treat and extend regimen, and the visual gains was as equal as compared to the monthly cohort. So what about non-responders? So as I said, the protocol T showed that 50% of the patients with persistent DME, they did not improve vision at 2 years. So why failure happens, or why there is resistance? It's due to, because sometimes you can have suboptimal response after 3 to 6 injections. And that could be due to a poor compliance, due to the inflammation component of the DME, or when the disease has reached a plateau phase where it's stopped responding to that particular anti-VEGF. So what to do in such a case? You can switch between anti-VEGF, you can switch to steroids, you can use a combination of both. A lot of practitioners mix both triamcinolone or anti-VEGF and give. You can do a focal laser with or a targeted PRP after doing an ultra-wide field fluorescein angiogram. And you also need to revise diagnosis, rule out macular ischemia as well as surgical causes of diabetic edema. So this is an example of a patient who, following 3 injections of ranibizumab as well as 1 Ozurdex, he still had persistent DME and vision was not improving. But on the OCT angio and the superficial vascular plexus, you can see a large area of capillary dropout involving the foveal avascular zone, suggestive of ischemia. So treatment was stopped at this point for this patient. So switching to anti-VEGF. So when you have resistance to bevacizumab, you can switch to ranibizumab or aflibercept. And if you're resistant to ranibizumab, then you can probably think of switching to aflibercept, or if the DME is chronic, even to a steroid. So you can switch anti-VEGF after 2 to 3 injections, where you'll know that the injection is not going to work and the DME is persistent and the vision is not improving beyond 612. So this is an example of a patient treated with this is the primary OCT, treated with 3 doses of ranibizumab. This huge foveal cyst with intraretinal cystic material refused to go. And after switching to aflibercept, we can see the reduction in the cystic material and reduction in the subfoveal thickness. And he's still on continued treatment and the vision has improved to 612. So what about corticosteroids? So we know DME is multifactorial. There is a multifactorial switch during the second half phase of the disease, where the VEGF-mediated cause of DME reduces and the inflammatory cause increases due to the increase, and this causes the increased vascular permeability. So steroids are helpful, but what are the current indications? So they're actually second-line agents based on a consensus panel for resistant chronic or recalcitrant DME who are non-responsive to 3 to 6 doses of anti-VEGF. So you can consider them in pseudophakic eyes, pregnant patients who require treatment for DME, because anti-VEGF effect on the placenta is not well known and it's not recommended. Patients with recent cardiovascular events, and it's also beneficial in post-vitrectomized eyes with diabetic edema. And also those who cannot follow up regularly. So this is a patient who has undergone Ozurdex injection in a chronic DME with a lot of hard exudates. So this was the same patient, 72-year-old, 636 vision. And after 2 doses of Ozurdex, we can see the flattening of the fovea with complete disappearance of cystoid spaces. There is mild foveal atrophy. That's why the vision has not improved very significantly. It's only 618. And this is a fundus photo of the same patient with the this is a fundus photo of this patient with the Ozurdex implant in the vitreous cavity. So another one with an ERM with chronic sciatic edema, 636 vision, and following Ozurdex, 1 dose of Ozurdex after 1 month, reduction in cystoid spaces, vision improved from 1 line to 6/18. So Ozurdex or steroids are helpful in these situations where you have advanced proliferative disease, where you cannot inject anti-VEGF because that will cause contraction of these fibrovascular bands and cause traction retinal detachment. So you can consider steroids in these patients when they are present with diabetic edema as the cause of their reduced vision. So what about eyes with center involving DME and good vision? So for that, we had protocol V, and what protocol we showed, which studied aflibercept versus observation and aflibercept PRN. So what the study showed is that you can observe these eyes with good vision, and at the end of 2 years of PRN aflibercept versus monthly aflibercept, the visual gains are almost the same, and the improvement in the OCT at the end of 2 years is equal in both the groups. Only thing is that in the aflibercept group, which is treated monthly, there is a sudden reduction in the initial phase of the treatment. And also the need for injections is reduced in the observation group. That was another conclusion from the protocol V. So example of a patient, 6/9 vision, center involving DME, treated, center involving DME, given 1 dose of aflibercept, and following that, vision is maintained at 6/9. At this point, decide to observe the patient, and he has been maintaining good vision 6/9 with a small cystic space. But because the vision is good, we just kept him on observation after 1 dose of aflibercept. So what about the real world outcomes? So RCT, the injection and the outcomes in RCT is different from the real world. In RCT, they gave 8, 9, 10 injections in a year, whereas in the real world, the average injections are only 3 or 4. And hence the visual acuity gains are inferior due to the cost of these injections and treatment of they spend a lot of money in treating their kidney disease and other issues. So they also do the poor socioeconomic status, and they cannot keep missing work and keep coming to the hospital to get these injections. So what happened in that protocol T after 2 years? So all those participants who had left protocol T, who had good vision, after their erratic follow-up, and now they have to pay for their injections. So following that, you can see they all had a drop in vision following exit from their protocol 3, that is exit from their randomized trial. So now biosimilars are available, which are 10 to 20% cheaper, no significant difference in visual or anatomical outcomes, and no significant adverse effects. What about vitrectomy for DME? To doing it only for recalcitrant DME without traction, there is little evidence. However, some clinicians still do vitrectomy. But however, removal of epiretinal membrane or taut hyaloid or VMT is definitely going to reduce the DME. And sometimes they may result in structural improvement with non-significant visual improvement. So coming to some special situations, I'm going to end in a couple of slides. So PDR with DME, you need to know whether it's advanced PDR or whether it's early PDR, in which you'll have to do pan-retinal photocoagulation and along with give anti-VEGF injections for diabetic edema. If it's a lot of tractional components are there, then you probably should give steroids. DME with pseudophakia, you can have cystoid edema post pseudophakia, or you can have diabetic edema, which you need to rule it out by doing an FFA and then give the appropriate treatment. In pregnancy, as I mentioned before, steroids is the treatment of choice for DME. When you have DME with glaucoma, steroids are contraindicated. Anti-VEGFs monthly will be the treatment of choice there. DME after vitrectomy, there again the half-life of anti-VEGF is less, so you need to give steroids, long-lasting ones like Ozurdex. And DME, when you have with macular ischemia, anti-VEGFs or steroids will cause anatomical improvement, but vision will not improve. DME with cataract, earlier the thing was when you have DME with cataract, you do the cataract surgery, and along with that you can give an anti-VEGF injection. But now the consensus guidelines say that you have to dry out the DME completely with anti-VEGFs, and following that to do the cataract surgery, unless the cataract is so dense that you cannot see the fundus or you cannot evaluate the DME or the PDR status properly. DME with disc anomalies like papillopathy or NAION, you can treat with anti-VEGF or steroids. And those with mixed retinopathy, even their hypertensive needs to be controlled well to prevent progression. So in patients with dyslipidemia, lipid-lowering drugs have shown to reduce the hard exudates accumulating at the center. Also, those who are hypertension needs to be controlled with physician. Renal disease, some physicians ask for clearance from the some ophthalmologists ask for clearance from the nephrologist before injecting anti-VEGF for such patients, because anti-VEGF has shown to cause increased in the exacerbation of the renal disease. Those with cardiovascular disease, anti-VEGFs are contraindicated for at least 3 months before after the event. And those with anemia, you need to have an anemia correction. And those with active systemic infection needs to be treated properly with antibiotics. And following a clearance, then only you go ahead with the anti-VEGF treatment. So in the Indian scenario, cost is a major deciding factor. You have numerous options. You need to talk to the patient and tell them to get a good control of hypertension, nephropathy, dyslipidemia, etc. and you have to tailor results for individual patients. So to conclude, the choice of anti-VEGF depends totally on the patient as well as the surgeon, and based on the affordability and the surgeon preference. Protocols can be personalized, so you have to talk to them. Monthly dosing needs to be done to dry out the macula. You patients who have access to aflibercept can afford it. Visual, and those with visual acuity less than 20/50, you can consider aflibercept in them. And those who have good vision, more than 6/9, you can probably just observe those patients. You need to tell to the patient that if you undergo early intensive treatment in the first year, then you'll dose of anti-VEGFs is reduced in the second and the third year. And for non-center involving DME, you have a choice of focal laser also. So outcomes depend on how you start treatment. So it's critical to start early. 6/12, 6/9 vision, you need to start treatment. You need to identify barriers to achieving adequate treatment. What is causing the patient from not following up and not taking the treatment? So also you should know the proportion of suboptimal or non-responders will be there around 50%. So future, we need to have anti-VEGFs with increased durability, which are being studied. Brolucizumab now is there out in the market, approved for DME, and you need to have drugs targeting other alternate pathways. So these are my references, and thank you.
Thanks, Dr. Varghese. That was a wonderful talk. And you covered almost A to Z of diabetic retinopathy and treatment. Thanks a lot.
Thank you. Thank you.
So I think I think the audience is also a retina surgeon. I would like everyone to please switch on their cameras if possible so that we can see each other. And my question is, and please kindly unmute also. So Shishir, to you. So when you switch between anti-VEGF from one anti-VEGF to another one, or maybe anti-VEGF to steroid, as you rightly said that the steroids is not the primary line of treatment. So what are the OCT biomarkers we look at when we want to shift from one anti-VEGF to another anti-VEGF, or maybe one anti-VEGF to dexamethasone Ozurdex implant?
Yeah, so the OCT biomarkers are presence of these subretinal hyperreflective dots or intraretinal hyperreflective dots. When you have this typical pearl necklace sign, where are these multiple dots which are lining the cyst. Sometimes you even have this retinal macroaneurysm, what you call, or a large microaneurysm, which you see, which these kind of OCTs as well as these patients, they don't really respond well to these weaker anti-VEGFs. So in such a situation, I'll probably think of giving I definitely won't give steroid as the first choice. I will always give an anti-VEGF, a better one like aflibercept, or if you cannot afford that, then definitely ranibizumab. And following that only, I will switch if there is no response after 3 injections. I will at least give 3 injections and then take a call.
Do you give triamcinolone also intravitreal IVTA, or?
Yeah, we do give. I'm a bit scared to give, but I do give, especially in pseudophakic patients. The glaucoma and cataract is slightly more in triamcinolone as compared to Ozurdex. Ozurdex is hardly I see, but I do see in triamcinolone and this thing. But I do give those who cannot afford.
Dr. Rana, Dr. Ankur, Dr. Avdesh, anything you want to add? Kindly go ahead. Feel free. Dr. Rana, please. Yeah, thanks.
In OCT biomarkers, one of the biomarkers, which responds well to the Ozurdex is if there's a hyperreflectivity within the cystic spaces, which is suggestive of one of the inflammatory components.
So would you use it as a primary treatment if you see these hyperreflective dots and the cyst with these hyperreflective dots? Would you still consider anti-VEGF, or you'll go straight away to Ozurdex? Let's say the patient presents with these OCT biomarkers suggestive of inflammatory pathology more as compared to leakage. It's a hard
To be
question, I
very
know.
honest, yeah, I start with anti-VEGF only, sir, for the initial 3 injections.
So that's what most of us do. And to be fair to system and to the patient, I normally start with the razumab rather than going to aflibercept, even if the vision is poor, and then maybe step up the treatment. That's what I do. Do you consider?
Yes.
Do you start with aflibercept straight away in some cases?
Razumab is quite good, sir. I have good experience with Razumab. But this last time in that VRSI as well as the general consensus, they said that aflibercept is good, but I do give them a choice. We also have that scheme, so I do give them an option of taking aflibercept treatment first. But if they're not affordable, I go to other biosimilars or even ranibizumab.
Anything anyone wants to add, Dr. Ankur? Yes.
Sir, in my personal experience, what I have seen is that, am I audible? Yeah. So in my personal experience, what I have seen is that if there is, the thickness, there are large cystic spaces, and you have to choose between aflibercept and Razumab. These patients, treatment-naive patient, would do better with aflibercept. But the patient who just have cystic spaces, which are the thickness is not too huge, there is no subretinal fluid, they tend to do pretty well with Razumab itself. Apart from that, what we have just discussed is that the presence of hyperreflective foci, which are nothing but the inflammatory component in the retina. All these things, the presence of the inflammatory marker per se does not. They do tend to tell us this telltale sign that these patients are going to do well with the steroids. But apart from that, because still the main culprit is VEGF, so you can start with anti-VEGF. And if they don't respond because you have something in your own OCT that they are going to do well with steroids, you can add steroids later. Some of my colleagues have used both of them together, which I don't. But then I don't have the experience with that also, and I don't know how to go on with that. But then they have shown that their patient, when we give this cocktail therapy, they tend to do well.
That's
yeah, please go ahead.
Yes, doctor.
Yeah, and another thing what I've observed, that suppose there is a non-responder, and at times I combine a suprachoroidal triamcinolone with a cannula which we designed a few years back, and that works fantastically. That is another addition to our therapeutic armamentarium when we are actually looking at the affordability and economic angle.
So that's what we always talk about, suprachoroidal space and the effect. I think I've read your paper or maybe a communication where you said that the effect comes within 3-4 days after giving it in suprachoroidal space as compared to supplements or intravitreal.
Yes, and actually there have been a lot of studies on animal models and therapeutically also. Even the response in some of the macular edema cases, not diabetic, it takes almost a week, but patients with pseudophakic CME, diabetic patient undergoing cataract surgery, day one, you see that there is almost 30 to 40% reduction in the size of the cyst which you see on the OCT. So it's actually, you have to do it to believe it. The result is absolutely miraculous.
Thanks. If there is nothing else, shall we move to our next speaker, Dr. Rana?
Sure.
Dr. Rana is the head of Retina UV and ROP services at Command Hospital, Kolkata. And over to you, Dr. Rana. Let's learn about ROP.
Yeah, good evening, everyone. Once again, I would like to thank AIUS and Allergan for giving me this opportunity. So I shall be speaking on very basics of the management of retinopathy of prematurity. Retinopathy of prematurity is a proliferative retinopathy affecting premature infants of low birth weight and the young gestational age. So the magnitude of ROP is 20 million children are born annually in India. 3% are born prematurely. 10% of them are admitted to NICUs, and 10% of those admitted in the NICUs are at the high risk of developing ROP. So let's put it in a simple way. Approximately 2 crore children are born in India every year, and 6 lakh children are born prematurely. That is 3% of the total children born, and 60,000 children are at the risk of developing ROP. So it is estimated that around 5,000 children go blind in the country every year due to this entirely preventable cause of childhood blindness. So what are the risk factors for ROP? Apart from the low birth weight and the low gestational age, the others are anemia, cardiac defects, multiple blood transfusions, respiratory distress syndrome, high exposure to the oxygen for prolonged periods, apnea, and sepsis. So all these factors directly or indirectly, they increase the VEGF load and leads to the abnormal proliferation. Now let's understand the basic pathophysiology behind retinopathy of prematurity. When the baby is in utero, there is a relative environment of hypoxia. So, because of that relative environment of hypoxia, there is production of the VEGF level, which is required for the normal production of the vessels. However, when the baby is born prematurely, then he is exposed to the relatively hypoxic environment. And in addition to that, when we give the oxygen supplementation, there is further hypoxic environment. So what that hypoxic environment leads to, that leads to the cessation of the vessels. So that is vaso-obliteration phase. Now, because of that vaso-obliteration phase, there is a lot of ischemia. Now there is abnormal increase in the VEGF levels, which leads to the abnormal proliferation, and that is a vasoproliferative phase, and that leads to the retinal neovascularization and retinopathy of prematurity. So, whom to screen? Screening should be carried out for the infants with either of the following: birth weight less than 2,000 grams, or gestation age less than 34 weeks, or infants with an unstable clinical course who are at high risk as determined by the neonatologist or pediatrician. And when to screen? So there's a very famous line by Dr. Subhadra ma'am, that is, "Tees din roshni ki." So we must remember that ROP screening should be completed by fourth week of birth. And infants with period of gestation less than 28 weeks gestation or less than 1200 grams birth weight should be first screened at 2 to 3 weeks after delivery. So what should be the duration and frequency? So initial examination, the screening examination will continue at least every 2 weeks until vascularization of the retina reaches normal completion, or until ROP regresses, or until ROP requiring treatment develops. And where should we examine? So best examined in the neonatal unit itself under the supervision of attending pediatrician or neonatologist. And it is not at all wise to transport these small babies to the ophthalmic OPDs, where there is a lot of rush and they are prone to infection, and we don't have any even resuscitation equipment also. If screened at ophthalmologist office, there should be an arrangement for the basic resuscitation equipment. What are the equipments we require for the screening? These are the indirect ophthalmoscope, uh, then 28 after lens, dilating drops consisting of propygamide and phenylephrine, paraffin drops. This is jelly in case we want to do the red cam imaging, and this is the lens for the red cam imaging. So we also need the speculum. We can do without speculum also, just by opening the eyelids with the fingers. And if we want to see on indentation, we can use this indenter also. As we all know that it is highly medical legal, so for any screening, for any treatment, we must have the proper documentation and document, and that has to be conveyed to the parents of the baby. This is the red cam. If we want to do the digital imaging, we want to do the we want to take the pictures. So for doing the red cam, it's again if it is done in the NICU, it is better. And for that, we have to take care of the sepsis. And this is the red cam picture which you can see. So for steps of the screening, we have to put the tropicamide plus phenylephrine concentration. So normally we get the tropicamide and phenylephrine, and tropicamide 8% and phenylephrine 5%. So we have to dilute it to make it half concentration. One of the drops which we get in the market by the name of Prothap P semi, it already comes in the concentration of phenylephrine 2.5%. So only one drop at a time, and maximum 2 drops to be instilled at the gap of 10 minutes. We have to wipe off the excess drops and not to put the drop more than 2 times. Why? Because it can lead to the decreased gut motility, and it may lead to the regurgitation, it may lead to abdominal distension, apnea because of the bronchospasm, and also the reports of necrotizing enterocolitis are there. So before screening, we have to scrub. We have to scrub our hands. We have to scrub the 28D and with the soap and water at least. And we have to use this Alfonso speculum, which has to be sterile. It is required only if we want to do the screening. We want to take the pictures with the red cam, which is required for the documentation. So while doing the ROP screening, we have to stand to the eye to be screened, and we have to turn the turn the eye towards the area to be seen. For example, if we want to see the temporal retina, we have to turn the head towards the temporal side. And if we want to see the nasal retina, we have to turn the head towards the nasal side. What should be the follow-up intervals for the infants at risk? Uh, Follow-up examination for the infants at risk should be done 2 to 3 weeks, intervals until the retina is fully vascularized, and if ROP is present. So, stage 1, 2, or 3. ROP without crust disease should be screened at least weekly because there is a high risk of disease progression, and treatment would be required in crust disease irrespective of the stage, that is 1, 2, or 3 in zone 1. Retinal vascularization commences around the 13th week of gestation and proceeding centrifugally from the periverbal region to the peripheral retina. So there are three concentric retinal zones which are centered on the disc and extend to the ora serrata. So these are the three zones: zone 1, zone 2, and zone 3. Zone 1, we can see that it is centered over the disc with radius double to the this distance from the disc to the macula. And then there's a zone 2, which we can see in zone 2, it is from the disc to from the zone 1 to the ora serrata nasally, and the equal distance superiorly, inferiorly, and temporally. And the temporal crescent is a zone 3. Zone 3. So, as per the new guidelines, that is ICROP3, there is one term which has been introduced, that is a this posterior zone 2. So the posterior zone 2 is nothing but the two disc diameters ahead of the zone 1. So it is basically for the prognosis of the patient. Like posterior zone 2 prognosis will be worse as compared to the anterior zone 2. So zone 1, 2, and 3 already have discussed. So the stages of the active disease. So stage 1 is the demarcation line, which is at the border between the vascular and the avascular retina. Stage 1 is the demarcation line we can see with the white arrows and associated with the notch shown in these black arrowheads between vascular arcades that would be considered zone 1 secondary to notch 2. Now, previous to the ICROP3 classification, it was considered like zone 2 ROP. However, in the ICROP3 classifications, uh, it has been introduced that this notch, which is present, if it goes to the zone 1, then we'll not say that we will say the diagnosis like ROP stage 1, zone 2, secondary to the notch. And if notch is not present and it is only in the zone 2, then again it will be zone 2, stage 1, zone 2 only. Stage 2, we can see the ridge, which is raised and thicker than the stage 1. Stage 3 is disease with extraretinal neovascularization. And in this picture, we can see the plus disease also, where we can see the dilatation and tortuosity of the vessels. Then we have stage 4, stage 4A, and stage 4B. Stage 4A is retinal detachment not involving fovea, whereas stage 4 will be subtotal RD involving the fovea. Stage 5 is total retinal detachment and it is classified by the configuration of the funnel, that is open, 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 close, 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 close. This classification is based on the ultrasound, where we can see whether it is open, 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 close. Now, this open word, first word open is for uh, the retina which is behind the lens, and the second word, that is whether open or closed, it is for the area which is ahead to the posteriorly or in front of the disc. As per the ICROP3 classification, again, stage 5 has been divided into three groups, that is 5A, 5B, and 5C. So the 5A is the optic disc is visible by the ophthalmoscopy, suggesting the open funnel detachment. 5B is the optic disc is not visible, secondary to the retrolental fibrovascular tissue or closed funnel detachment. And 5C is associated with the anterior segment abnormalities, that is the anterior lens displacement, marked anterior chamber shallowing, iridocapsular adhesions, capsule endothelial adhesion with central corneal opacifications, or a combination thereof. So these are the stages where we can see the stage 1, stage 2, stage 3 with extraretinal proliferation, and stage 4, and this is stage 5. Plus and the pre-plus disease. So the plus disease spectrum should be determined from the vessels within zone 1, and rather than from only vessels within the field of narrow angle photographs, and rather than from the number of currents of abnormality. All these are the guidelines which has been given as per the ICE ROP3 edition now. And the plus disease includes features of vascular engorgement of the iris, poor pupillary dilatation, and the peripheral retinal vascular engorgement. Pre-plus disease is defined to represent retinal vascular dilatation and tortuosity that is abnormal but insufficient for plus disease. So in the picture A, we can see the pre-plus disease where there is mild dilatation and tortuosity. And this also shows pre-plus disease with notable arterial tortuosity but with minimal venous dilatation. And in these pictures, we can see there is extensive dilatation and tortuosity, which is suggestive of plus disease. Aggressive ROP. Earlier, it was called as aggressive APROP. That is, now it is called as AROP. That is aggressive ROP. It was earlier it was the word P that was posterior was included, but now this word has been taken out from this, as it can be there in the anterior region also. So the rapid development of the pathological neovascularization and severe plus disease without progression being observed through the typical stages of ROP, and it consists anterior to posteriorly. It will be poor dilatation of the pupils, neovascularization of the iris will be present, and neovascularization elsewhere can be present. There will be plus disease, that is dilatation of tortuosity, and we can see the shunt vessel, that is the AV anastomosis, will be present. So this is a fundus photograph of the aggressive ROP, which is showing this with the white arrows. We can see the loop which is present there, and we can also see the dilatation and tortuosity. And first, we will not see any stage, no, neither stage 1 or 2 is there. In the ICROP3 guidelines, the one ROP which is there in the literature, that is a hybrid ROP, has not been included, but it has been it was discussed that it will be included subsequently in this classification. Hybrid ROP is nothing but when you see the features of aggressive ROP, and at places you see the stages also. So that is a combination of aggressive ROP as well as the stage ROP. So let's come to the treatment. So any eyes meeting the criteria. Uh, Basically, peripheral retinal ablative treatment, whereas type 2 ROPs can be monitored with short intervals. And the laser ablative treatment can be considered if type 2 ROP eyes progress to the type 1 ROP or threshold ROP. So what is a type 1 ROP? It has been classified zone 1, any stage ROP with plus disease. In zone 1, stage 3 ROP, even without plus disease. And zone 2, stage 2 or 3 ROP with plus disease. So if type 1 ROP is there, we have to administer the treatment. As of now, it was given peripheral ablation treatment, but now we have the anti-VEGF treatments also. And in this stage ROPs also, in fact, the anti-VEGF has been given these days, apart from the aggressive ROP. And type 2 ROP is wait and watch for the progression. That is zone 1, stage 1, or 2 ROP without plus disease, and zone 2 is stage 3 ROP without plus disease. So the use of anti-VEGFs to treat ROP, the indications mainly are monotherapy in type 1 ROP in selected cases, aggressive ROP. In aggressive ROP, particularly if vascularization is only up to the zone 1 or posterior zone 1. And after failure in laser photocoagulation or before the surgical intervention in stage 4 and 5, where we can see that there is an increased vascular component and we want to regress that vascular component to decrease the bleeding intraoperatively. If we want to use the anti-VEGF, then we give the anti-VEGF in both the eyes simultaneously, where we have to prepare two different sets to prevent the endophthalmitis, and it can be given very well in the under topical anesthesia only. So we use the alfonso speculum in both the eyes after cleaning and draping, and make these two sets and give the dose which is half of the adult dose. So laser treatment, we mostly use double frequency double NDR laser 532. And currently the laser is the standard treatment for ROP still. The laser is to be done according to the ETROP guidelines. Once decided, laser is to be applied within 48 hours of the diagnosis. And if the diagnosis is aggressive ROP, laser is to be done as soon as possible. And confluent laser burns to be applied to the whole of the avascular retina. So before doing the laser, we have to maintain the asepsis, because asepsis itself, because sepsis itself is the cause for the retinopathy prematurity, and it has to be done under the ICU setting, under the pediatrician or the neonatologist, and we have to straddle the baby. We have to maintain the temperature. We have to put the monitor on, and this is a double frequency NDR laser, which is being done in the ROP baby. The surgical approaches in ROP are we can use the scleral buckle, lens sparing vitrectomy, and lensectomy and vitrectomy, especially in the stage 5 ROP. At the grassroots, the most important things to know are the prevention, because a number of ROPs, they can be prevented if we know the basics. So the referral to the tertiary care center in utero transfer. So what is in utero transfer? In utero transfer is that whenever the gynecologist, he is expecting that there's a high risk pregnancy, so instead of delivering that baby in a small institute, that patient should be referred to the higher institute for the delivery, where facilities of NICU are available. First golden hour is very important, where most of the some of the pediatricians, they might try to save the baby by giving 100% this by maintaining the 100% saturation, which is actually harmful. So we should not keep the target of 100% saturation. CPAP is much preferred early non-invasive therapy. Saturation targets should be monitored between 87 to 94%, and we have to avoid fluctuation of oxygen. Even if we are maintaining 87 to 94%, but at times, somebody is coming, he's increasing to 100%, other one is coming, he's decreasing, he's keeping the saturation to 94%. So that fluctuations, they do a lot of harm. So we have to avoid that. Pulse oximeters, we should use as much as possible. Blended air should be used, but we know that blenders are not available anywhere, and blenders are costly. Education of nursing officers is very important, because they are the ones who are managing the babies in and out, day and night in the NICU. Again, we have to avoid fluctuations of SpO2 while on oxygen. and more nursing officers. We have to have a ratio of 1:1, which is practically not possible in our country. And but I mean, better the ratio, better will be the results. And at least what we can do is hand washing, and we can maintain the asepsis, because that is also one of the bigger causes for the ROP. So this is a painting by Pablo Picasso, which was painted in the 1903, the old guitarist, where we can see a saddened face with the guitar. Guitar is one of the signs of happiness, and so if patient is blind, then it shows what havoc can be there in the harmony. So for the general ophthalmologist, and the message which with this presentation, I would like to give is that even at the end of this presentation, if we learn this line, that ROP screening should be done in babies who are less than 2 kgs or less than 34 weeks of period of gestation. And when it should be done uh, by day 30th of the birth. That is the Roshni Ke, they should remember. Then the motive of this presentation will suffice. Thank you so much.
That was a wonderful talk, Dr. Anna. Thanks for enlightening us, and you've covered most of it. The only thing, see, I was trained under Dr. Subhadra Jalali for ROP. I don't do ROP anymore. But I would like your take on nowadays. A lot of I've seen retina people shifting to anti-VEGF. The few people who are saying that they have stopped doing lasers for ROP. What is your take on that? Where do we stand with anti-VEGF?
Yes, sir. Sir, we have, one this. In fact, one of the thesis was there on the anti-VEGF while I was in PGI. So it was to compare both. And what we see is that despite of this also, there are a lot of differences despite of the anti-VEGF. And the one second thing which is there with anti-VEGF is that once you give the anti-VEGF, we have to keep patient under close observation. At least every weekly patient has to come, because all of a sudden the effect of the anti-VEGF goes, and the disease comes very strongly as compared to what it was earlier, and it can create havoc at times. So one, if the patient is willing for the regular follow-up, that has to be told to the patient before giving the anti-VEGF, number one. And secondly, one more thing is, one of the important considerations while giving anti-VEGF is, like, if disease in zone 1 or posterior zone 1, sir, where macula is not fully vascularized, then it is always better to give the anti-VEGF, because there is a lot of area which is there to laser. And now the results are there that myopia will be more with the laser as compared to the anti-VEGF. Yes. So they induces less myopia. So it's better to go for the vascularization. And if at times what happens with the anti-VEGF at times is that there is a cessation of the growth. Now neither it will regress, neither it will progressively, it will stay like this. So if that is also there, then we must laser that area anterior to that. What some people are doing is that they do the FFA, they see whether there is any leak, then they do the this laser beyond that area. And some, it's a very small area, so some still may observe that.
Thanks, Dr. Anna. If it's the house is open for all the participants, Dr. Varghese, Dr. Avdesh, Dr. Ankush, if you want to add anything.
Sir, one thing regarding use of anti-VEGF. Now, anti-VEGF in general practice or in retina practice is used like Gangajal. In whatever situation you find, you inject it. I have seen at least 2 babies during my fellowship at LVPI who were referred from up north, wherein they developed endophthalmitis in both the eyes. Because here we are using anti-VEGF in NICU conditions, which sometimes has candida or other atypical kind of microorganisms. So we have to be very, very careful, and anti-VEGF should actually be used only as a rescue, as Dr. Rana said, for posterior fold to vascularize. And definitely the follow-up has to be longer, maybe even till 70 weeks, because
Yes, sir.
otherwise the disease may get missed. When it returns back, it's more disastrous. And also the ROP crunch phenomena, which has been described with the use of anti-VEGFs. And also, while handling these babies in NICU, we have to be very, very careful about their general health. Even while doing lasers, they can get into apneic spells. And I have actually seen a baby in a very remote location who had fractures of possibly all the bones of body except the chest, all the long bones of the arm and hands, because the baby was held like that by the untrained sister of the NICU. And that laser lasted quite long, for maybe an hour plus. So we have to be very, very careful, and we should look at all these medico-legal angles. That's also.
Thanks, Dr. Oli. Thanks, Dr. Rana. That was a wonderful talk.
Thank you
Now
so
we'll
much.
shift to Professor Wing Commander Avdesh Oli. He is a vitreoretina surgeon at Command Hospital Air Force in Bangalore. Over to you, Dr. Oli. We're looking forward to this talk, near ways of managing aphakia. I think most of the retina surgeons, we are managing aphakia. So enlighten us, please.
Yes, can you see my presentation, sir?
Yes, it's there, and you're audible also.
Yeah, thank you, AIOS and Allergan, for this opportunity. I'll be talking about newer techniques for management of aphakia. So diagnosis of aphakia is straightforward, and it is absence of crystalline lens, and the most common causes are post-trauma, post-cataract surgery complications like lens drop, IOL drop, or following ICC, and certain conditions wherein congenitally the lens is absent or there is problem with the zonules. So first, for the general ophthalmologist, to avoid the situation that a patient would require SF IOL or a glued IOL, we should plan our surgery very well. This is for the beginners, that ophthalmic surgery is very dynamic. You are as good as a surgeon as your last case. So each and every step is important and interlinked. We should never try to fish out the nuclear fragments, and we should never try to pull out the dropping IOL, which is the natural tendency when we are beginning cataract surgeries. And never hope that IOL will stay with your prayers. It will need support of the sulcus for it to remain there next day morning. And the very best you can do to your patient is on table. So the simple cases which are non-complicated, you have intact sulcus, wherein you can go ahead and implant the lens with anterior vitrectomy, which can address the pathology. There should not be, if there is no vitreous traction and there is a support inferiorly, then you can implant. Otherwise, if a person is not trained, he should, in the immediate post-op period, control the inflammation, intraocular pressure, and refer such patients. So whenever you have a lens drop or you have an IOL drop, or you feel that any vitreous manipulation which anterior vitrectomy cannot handle, or you are not able to address all the sight-threatening complications and treat the retinal lesions, then you should refer the patient. You should never mix ego and vitreous, and that is a lethal cocktail which comes in a patient with sight-threatening complications. So coming on to the management, if we have intact capsular support, then we can go ahead and implant the 3-piece IOL in the sulcus. We should never implant a single-piece IOL because of the design. The patient will have recurrent uveitis and other problems. If we do not have capsular support, we have other options like AC IOL, iris claw lens, or scleral fixation of the intraocular lens. So scleral fixation could be done with the help of the sutures, or the newer IOLs like glued IOL or a flanged IOL, which are recently described. So as far as anterior segment intraocular lenses are concerned, AC IOLs, they are not totally out of practice. If you have an elderly patient who has conjunctival scarring, where scleral fixated IOL feasibility would be limited, he has a deep anterior chamber, then you can go ahead and implant an anterior chamber lens. Iris claw lenses, they have recently been popularized and they are being extensively used, Wherever the vitreous disturbance which you can handle, then you can go ahead and implant. But as a retina surgeon, I have operated on 2 retinal detachments following iris claw lenses and 1 dropped iris claw lens. So you have to exercise discretion in what patients you have to implant iris claw lenses. Sutured SFIOL are they are technically slightly demanding because you have to handle these 11-0 proline sutures, and you have problems associated with suture integration, knot exposure, and IOL tilt. The incision is also large, and the time taken for surgery is more. And in the post-operative period, also after years, maybe 5 years, 10 years, you may have suture erosion and lens dislocation. So looking at all these complications, the intrascleral haptic fixation techniques, they have become popular. And the most commonly used is a glued IOL, which has a definitive advantage that it can avoid hassles of suture. The smaller incision is a better option because you have a foldable lens, and refixation or explantation of the lens is easier. However, the long-term follow-up of at least flange IOL and that complications we are not really aware at this point in time, and the chances of dislocation with trauma are slightly more. For a beginning surgeon, the challenging steps for a glued IOL, which I feel, are exteriorizing the haptic and tucking of haptic into scleral tunnel. So you require, for doing this procedure, you require a 23 gauge needle to make the sclerotomy, vitreoretinal forceps to hold and exteriorize the haptic, and fibrin glue. Under appropriate anesthesia, the marking of cornea is done, and you make 2 scleral flaps. I prefer slightly off 3 and 9 meridian to avoid any major neurovascular plexus. And we have to plan if you are going for any combined procedure like lensectomy or IOL explantation. Then the 3-piece IOL is injected and haptics are exteriorized. And finally, the glue is used to fix the scleral flaps and the case is closed. So if you follow these steps meticulously, it's very difficult to make out whether a patient has undergone a phaco or a glued IOL. And planning is very, very important in doing this surgery. You have to look for any scars at your planned incision sites, whether it's conjunctiva or sclera, any pupillary abnormalities, because if a patient has traumatic mydriasis and you go ahead and do a glued IOL, now you have divided this optical zone into a phakic and a pseudophakic, which may lead to diplopia. So you have to look at the pupil in mesopic conditions and always keep 1 intraocular lens standby. Another 3-piece you should keep in your library of the same power. If there is any capsular remnant, you carefully assess that this capsular remnant you should not remove indiscriminately, because sometimes it, once opacified, it actually can be used as a prosthetic iris so that diplopia is avoided. Always have a look at white to white diameter. If it is more than 13, then chances of IOL dislocation are more. I had a patient in whom I repeated a glued IOL because the IOL dislocated in the first attempt. And then second time also, there was trivial trauma and the IOL got subluxated. Finally, I fixed the same lens in a vertical meridian because the white to white was less vertically. If it is 9 small eyes, then chances of UGH. And post-operatively, if it's a child, we should not forget, just after doing glued IOL, we should continue the management with amblyopia and refractive correction. This is a short video of the surgery, wherein the 180-degree axis is marked. And this marking is very, very important, not only for IOL centration, but exact exteriorization of the haptics. Then you mark 2.5 and make a lamellar scleral pocket, the flaps. And while making them, never hold these flaps, because otherwise, if you have amputation of the flap, then you will have difficulties later on. And this is the use of the AC maintainer. Now at 1 millimeters from the limbus, you make a 23 gauge sclerotomy, and you can use it for doing your other vitreoretinal procedure. So this is a case wherein the IOL dropped after the surgery. So we carefully shave the vitreous base and try to free the haptic which is entangled at the vitreous base. Any undue pull on the IOL, if suppose part of the IOL is visible from the pupil and we pull it out, that may lead us into troubles. We remove any remnants of the capsule, and then this IOL is picked with the active suction. And one of the haptics holding at the tip with a vitreoretinal forceps is taken out of this sclerotomy. And we should always take care that we hold only the tip, not at any other point. Otherwise, we will deform the haptic as we have done this side. So we are straightening. And then finally, it is placed in these scleral channels. And with the use of fibrin glue, after taking out the AC maintainer, we just close these scleral flaps and the conjunctiva overline. So that completes the surgery, but in the beginning few cases, haptic breakage is one of the complications. So we have to always keep a standby lens. Post-op day 1, we could have hypotony because we have made 23 gauge sclerotomies. And if we do another vitreoretinal procedure, then also these sclerotomies slightly enlarge. You could have a vitreous hemorrhage or hyphema, but that does not require any specific management. And it goes within 2 to 3 weeks. Cystoid macular edema, in a few cases, you could encounter this. And another important complication is pupillary capture on immediate post or delayed post-operative period. So now routinely we have started doing peripheral iridectomy for preventing iris-related complications. And after this, there is a significant reduction in any optic capture or iris-related complications. So when I started doing these glued IOLs, I was a fellow. So I started collecting my data, and we wrote this paper on surgical outcomes, complications, and learning curve of glued IOL of vitreoretinal fellow in training. So here, if you are beginning to do glued IOLs, then your time, as you see, my time as compared to my consultant is almost double. And then this time becomes comparable as and when we increase the number of cases which we have done. To overcome some of the problems of glued IOL, this elegant technique of flange IOL was described by Dr. Shin Yamane, in which instead of making the scleral flaps, we are making transconjunctival entry with a 30 gauge needle, and the haptic is exteriorized by pulling out the needles, and the end of the haptic which comes out is flanged so that it does not retract back. However, with this technique also, now there is a lot of concern about flange erosion or exposure and the risk of endophthalmitis. This is one of the editorials published recently in JCRS, which opens with a remark that only time will tell if it was time well spent. So the follow-up is an issue, and flange erosion and exposure is definitely a concern. So to overcome these challenges, we actually modified this technique 2 years back, wherein to address this flange exposure, we made 2 scleral pockets, and they were different from the flaps which are made in glued IOL technique. And instead of fibrin glue, because now we do not have scleral flaps, so we started using autologous blood as it is done in a routine pterygium surgery. And this saved us on the cost of the fibrin glue, and this technique we found was more replicable. This is one of the OCTs of one of the patients. You can see the flange here, which is well covered with the lamellar scleral tunnel. So the chances of exposure of this flange are very, very rare. This technique was published in Indian Journal of Ophthalmology. And here the only difference is that instead of making the flap, which is reflected here, the triangular flap, you are marking 2 millimeters from the limbus, and then you are starting your small tunnel here as it is shown by black arrow, and similarly on the other side. So these are the subsequent steps, which I think in this video it will be clear. So after marking this 2 millimeters, you make these scleral tunnels, and you do not actually require flaps for this. So now it is under direct visualization that you make the entry inside. So you know what is the intrascleral length, this haptic when it comes out, it will traverse. And then when it's out, you can flange the end so that it does not retract back. And the same procedure can be repeated on the other side. Once the haptic is out, you can flange it. And this is the pool of blood which we have used instead of fibrin glue. So in this technique, there is no flap of the sclera. It's just a tunnel which actually closes on its own. This blood is just to cover the conjunctiva over the scleral surface. So this is post-op day 1, absolutely central lens, and conjunctiva is well opposed. This was presented at one of the conferences, and it had won a certificate of innovation. But at this point also, we were not very happy. We had scleral pockets and autologous blood. But sometimes, because we were using 26 gauge needles, so sometimes the leading haptic used to retract back inside the eye. And it was very, very difficult to retrieve it back because we had already flanged the end of this haptic. So we added this vicryl loop to this modified technique to avoid retraction of the haptic, which in this video it can be seen. So this we actually try to address the haptic retraction and the other two components from the previous technique. So these are the lamellar scleral tunnels, and these are the needles which we devised, and we just tied a vicryl loop around this so that when the haptic comes out, we just slide this vicryl loop on the haptic. And these haptics are well covered with the scleral channels. And we just need to close this conjunctiva so you can use autologous blood.
Can't hear you, Dr. Wally. I hope other people are able to hear it.
The video
Yes.
voice you can hear?
Ah, okay.
Actually, only voiceover for some time.
All right. No problem.
But the voiceover you can listen, sir?
No, sir.
Oh,
So whatever you are speaking, we can hear that, but not the
Okay.
voiceover.
okay. So now you see here that these flanged ends, they are very well covered. And now we have to just close this conjunctiva. So autologous blood helps, but in some patients, if we are not able to achieve that, then you can put a suture or use a fibrin glue. So mainly these vicryl loops, they'll remain there for some time and then they absorb on its own. So with this technique, you can see that the flanged end is well covered. And then we saw the tilt of IOL in these patients, and we found that it is very, very minimal. And this technique does not require fibrin glue because the scleral tunnel closes on its own. And this was the publication from this modified technique, wherein the lens was absolutely stable and the tilt was minimal. So sometimes we in the OR, it's always not a sunny day. I had planned a glue dial for a patient, but the lens which came, the haptic was already, it was dislodged from the position. So sometimes you may have only a MiG-21, but you have to shoot a F-16. So I started surgery on this elderly lady. There was some other vitreoretinal procedure to be done. So I made these lamellar pockets, which are roughly 2 millimeters in length. And then I did a peripheral idectomy, and I always use cutter in low cut rates. And then vitrectomy was done. She had some suspected peripheral lesion, retinal lesion. And here I intended to do a double flange technique because the only IOL which I had was SF IOL with a eyelet in the haptic. So I passed a proline suture through this 26 gauge needle. And then it was exteriorized. Now I passed the other end of this suture through the eyelet and flanged it, which was repeated for both the sides. And then finally, the lens was placed in position. And just with the manipulation of the sutures, the centration and the tilt was adjusted, and finally the sutures were cut short and they were flanged. And she had good vision in the post-op period. She was 618, and the IOL was stable with minimal tilt. So sometimes we need to innovate, and such good results can be attained. So to conclude, multiple options are available for management of aphakia. But one thing is that all these techniques are evolving. The choice of technique is based on condition of the eye. We need to see associated ocular features. The pupil size, which as I told is very important. You could actually induce diplopia if you do not take care of the mydriasis which the patient has, iris defects or aniridia. In case of aniridia, you will have to use a aniridia lens. Then always look at conjunctival scarring, scleral thinning, and staphyloma, because for any lamellar scleral dissection, you need to look at these aspects. And wide to wide diameter, if it is more than 13, then the IOL will be unstable. And also at the surgeon's expertise, his competence and comfort. My acknowledgements to my mentor, Dr. Divya at LVPI. Thank you.
That was a wonderful, wonderful talk, Dr. Oli. And thanks for sharing the tips. And we've been using all these techniques. And over the years, what I've realized is patients who are, 50 plus and 60,
Yes.
ACIs done by vitreoretinal surgeons, they are as good as any other lens. They take less time. The only thing is probably the incision size, which has to be enlarged, and consideration for the endothelial count. But otherwise, we've been doing, yes, as you said, rightly said, young patient, we don't have any other choice, but we've been using iris claw lenses quite often. Sometimes they are messy, but sometimes the results are very good. Once you look at the eye, in the mid-dilated pupil, it seems that patient will have a lot of problems with the movement of lens, with the eye movement. But somehow they manage very well, and the patients are happy.
Yes, sir.
So the house is open for comment, Dr. Varghese, Dr. Rana, Dr. Ankur, if you want to add. So we all have, sorry.
Actually, we also published on glueless, sutureless, sclerally fixated IOLs in the Journal of Eye. Around 250 patients we had done, and quite good results actually. But now, after coming to private practice, I don't leave SFILs in the hand of anterior segment surgeons. I prefer to do it myself. I do a complete core vitrectomy. I don't induce PVD, and I do a 360 endo laser, because if an RD happens, then it's a nightmare managing RD with SFIL inside. So yeah, that's
SFIL, you mean the sutured one, sir?
No. Glueless, sutureless. So yeah,
okay.
No, so glueless, sutureless. I bury into the tunnel, but I do a 360 endo laser too. That's I can sleep at night.
Yes, correct. Because sometimes that if it is not flange, it's a plain blue dial, then suppose you do excessive scleral depression, sometimes the IOL may actually subluxate and those haptics may come out. So that is the advantage of this flanged technique, wherein it will, at least it will not go inside.
Yeah.
Wonderful. Thanks, Dr. Oli. Now we'll move to last speaker of our day today, Dr. Ankur Singh, who is professor at UCMS and GTB Hospitals, Delhi, and he'll be talking on OCT angiography. And OCT angiography has become, initially when it came, we were not sure the place for OCTA, but now, as and when we are using it more and more, I think this is another gadget which has to be added to our armamentarium. Over to you, Dr. Ankur.
Yeah, thank you, sir. Am I audible?
Yes, you are.
Yeah. Thank you, sir. I must, after Dr. Avdesh, excellent surgeries. I have and now coming to the medical retina OCT, I have a big benchmark to meet. So I would like to start with my OCT angio slides. So OCT angio has been now there for some time. We know that it's a nascent, fast, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormality. It provides us with cross-sectional and en-face images, which let us assess the structure abnormalities, perfusion abnormalities, vascular flow abnormalities. Unlike FFA and ICG that treats the retina as a single layer, OCT angio help us to detect vascular flow abnormalities in superficial, intermediate, deep retinal capillary plexus, as well as choriocapillaries. So then there are terminologies in OCT like en-face OCT. So en-face OCT is nothing but 2D representation of the 3D volumetric data. The data acquired by the machine is represented as a 2D view at a particular predefined site or the predefined segment is the en-face OCT. And between the amount of space of retina between these two segments is known as slabs. If the patient moves his eye during the examination, then we have these jagged lines as we see over here, these jagged lines. So nowadays, the new machine correct them by themselves. We have projection artifacts. Projection artifacts are the artifacts of these vessels from the superficial retinal capillary plexus being projected on the deeper capillary plexus. Newer machine have these newer machine have the technology to correct these anomalies by themselves. So then there are flow areas, flow void areas, and flow indices. Why do we need these flow indices? Because these are quantifiable variables. These are quantifiable variables can be calculated by the machine itself, which includes foveal avascular zone area, as we can see over here. This is the foveal avascular zone over here. And then there's a acircularity index. Acircularity index is nothing but the diameter of the flow vascular area in comparison to the circle drawn touching the boundaries of the foveal avascular area. So we compare the ratio. If the avascular index is going up, this means there is a problem with the FAZ. The FAZ is getting larger. We have vessel density. That is total length of vessels per unit area. Foveal density 300. That is the density of the vessels. 300 micron around the fovea seen over here. Then we have perfusion density, that is total perfusion area per perfusion unit area. Then we have extra foveal avascular area. This is the areas which have these are non-perfusion areas outside the 1 mm diameter circle centered over the fovea. So what this help? How these quantifiable variable helped us? So Redkausis and et al. In their study suggested that the FD300 is a sensitive biomarker in diabetes to detect microvascular changes in diabetes even before the clinical sign of DR. Extra foveal avascular area in superficial capillary plexus is the most sensitive biomarker to discriminate a non-diabetic retinopathy patient from an NPDR patient. And vessel density in the deep capillary plexus is a sensitive biomarker to distinguish between NPDR and PDR. So if you see this arrow, which is showing that as the disease progresses, as it shifts from NPDR to PDR, there are a lot of changes that are happening, which can be read by these machines. So in future, an AI algorithm can detect the progression of the disease even from the NPDR to PDR, and that would help a lot of population where the retina retina surgeons are a bit scarce, or the machine by itself can, send back us the data that this patient is progressing towards DR, because at the same time we can correlate that with his abnormal systemic profile. OCT angio has also let us to discriminate between the NVDs and collaterals. So how do we do that? Is by looking at the vessels, the type of vessels. So we know that by now that NVDs or NVE are retina vessels, while collaterals are meandering vessels. The way you distinguish them is by looking at in which plane or segmentation or slab do you see. If you see them in the vitreous slab, then probably these are new vessels. If you are seeing them in the radial peripapillary capillary plane, then this is an collateral around the disc. Belli et al. In their initial study published that if you see those abnormal flow areas, and these are in the vitreous, so this is nothing but an NVD. So these can be quantified. Post PRP, we can measure the decrease in the size of these NVDs, and you can be happy that your things are moving the right direction. Patient does not have to undergo serial FFA for that. OCT angio has helped us. If you see an abnormality in the your structural OCT and you think what it is, if is it a CNVM or it is something else, you just do an OCT angio in these kind of patients. You will be able to discriminate that not even the presence of CNVM. You can also know which type of CNVM, either type 1, type 2, type 3. At the same time, the patients which had those OCT abnormalities as seen over here, and you are worried what it is. So do an OCT angio. You might find out an MNV, macular neovascularization, which is not going to leak on FFA. So now you know that this is a patient which might have a full fulminant CNVM in future. You can follow up that patient in that way, counsel the patient about injections, and there you go. Apart from that, if you see an abnormal flow in the superficial layer coming down through all the deep layers, at the same time, you find these abnormal vessels in the superficial capillary plexus, deeper capillary plexus, then it's a retinal angiomatous proliferans. That's a RAP lesion. There it is. So it is important, whenever you see abnormal vessel, when I started reading OCT angio, I used to get excited and say, oh my God, these are the abnormal vessels over here. But then always look at the segmentation. If the segmentation is gone wrong, then you are, getting a data which is not there. So always try to correlate with I always try to see the segmentation and try to correlate the picture that you see on the NFAS OCT. So when you correct the segmentation, no abnormality detected. At the same time, always correlate OCT angio with the structural OCT, because here you are confused. Is this is a fluvoid area? Is this fluid? So when you correlate this with the structural OCT, you will know that this is a fluid area and this is not a fluvoid ischemic area. You can clearly identify that this is a CNP area or a fluvoid area on OCT angio, and this is just the intraretinal cystic fluid spaces. And then there are new terminology like sickle cell maculopathy, which is very difficult to visualize. And sometimes you can't even see them in indirect. Patient comes with diminution of vision. Sometimes you do see them as an parafoveal slight whitening happening around the fovea. FFA is not giving you much information. Do an OCT angio. You will see that the superficial capillary plexus will show these fluvoid areas. And later on, when these retinal thinning happens, you know that this patient was of sickle cell maculopathy. At the same time, and Sharaf et al. Termed the award, which is known as paracentral acute middle maculopathy, which literally affect the deeper capillary plexus. And when FFA treats the retina as a unilayer, it's very difficult to identify these things. So this is something which has OCT has opened a new paradigm. You can see anything which is affecting just the particular part of the capillary plexus. If it might be affecting superficial, it might be affecting deep. So in PAM, you see the deeper capillary plexus affecting, and you can visualize this as a fluvoid area as seen over here on an OCT angio. So now we have wider field OCT. We have OCT which provide us visualization of even up till the 14. I would not like to mention the name, but then the new upcoming machine of a Swepso OCT, which is going to open this paradigm, and you have 14 by 14 montage, and you can see all the way to periphery. And even if you have a neovascularization elsewhere, and this is a patient of RVO, and you want to see now when you have to do a laser, how will it behave? So do a laser, quantify those NV, see them retract, when these and we become mature, they will not have that good circulation of the blood, will help us to visualize them as a contraction of those NVEs, and yeah, the patient is doing well. So OCT is just not limited to the retina. It is something which is also help us to identify diseases which are affecting the choroid. So we have seen on ICG, there's VKS show those flow-void areas which are site of granulomas. The same are visualized on the OCT angio as seen over here. And as you know, as our gold standard teaching goes on ICG, when those flow-void areas diminish or reduce, we know that now we can stop the treatment. So we don't have to keep we don't have to keep doing those investigations again and again, and ICG being invasive. You can just do an OCT angio, and you feed, even the retina is attached, and you still see those spaces, treat the patient. And when they are gone, even the retina architecture is going to be same. Stop the treatment. At the same time, OCT angio has also made us to understand more that white dot syndromes can have a different, visualization of OCT angio. So just like in multiple evanescent white dot syndrome, the OCT angio does not on the capillary place does not show any flow-void area. So though it has capillaritis, but then OCT angio, because it does not capture the limitation of the OCT angio per se, will differentiate this white dot syndrome from the others. So then as I've spoken previously, we have a wide field OCT angio and a disease like IRWAN, which has those peripheral avascular areas, those telangiectatic vessels, the aneurysmal dilatation, and everything can be visualized with the help of newer wide field OCT angios. In another study which was published, this image published by Brezana et al., Swepsos OCTs, which we have two companies, have better penetration. So in this case, when the surgeon did an FFA, he was not able to know what is happening behind this hemorrhage lying on the superior to the fovea. So did a OCT angio with the Swepsos OCT, better penetration, and there it is. You have a macroaneurysm with blood. So apart from that, you have chronic CSC patients, which you don't know why they are not responding to an OCT, and you might find a CNVM. You can see the progression and as well as therapeutic response in macular telangiectasia type 2. In glaucoma, look at the disc perfusion. If it is less, then think again. This might be a periperimetric glaucoma. And apart from that, there are a lot of diseases in which OCT angio can be used extensively. So whenever we start using OCT angio, we should always remember this, know the anatomy first, because structural OCT, without structural OCT correlation, OCT angio can really give you dubious results. And at the same time, know that you should adjust segmentation manually, because if you don't see the segmentations and don't correlate with your findings, you might end up with erroneous results. As I've spoken earlier, correlate with the structural OCT, apply the right scanning protocol. So when you are using a small scan size, the multiple scans taken at a particular place, or the scanning density of the machine is high. So it gives you better resolution. So in a case of AMD, use a smaller frame, 3x3 frame. And if you want to see some diseases which have a, with like diabetic retinopathy or retinal vascular diseases, go for a bigger frame like 6x6, 12x12, or even 8x8. Scanning part is easy. The good thing is we don't have to have an expertise to do an OCT angio now. These machines with a higher, faster scanning rate, in a jiffy, you get an OCT scan. You don't need to be expert, because previously doing an FFA used to be a problem. You have to move the scan from this place to that place. At the same time, now these newer machine, wider field machines, yeah, things are easy, but still the invasiveness doesn't go away. So non-invasive, fast, and literally it doesn't take time. But then yes, now you have to interpret, because it's a lot of data that is being provided to the surgeon. You do the segmentation, try to assess the vessels, and it's still we still are understanding the machine. A lot of data is there. A lot of diseases are being observed on OCT angios, or which have been previously seen on the gold standard test. But there's still a lot to be known about this. And at the end, all I say is this: it's not even a difficult technology. It's a very easy, surgeon-friendly technology. Practice, and you will learn. Thank you.
Well, thanks a lot, Dr. Ankur. That was a wonderful talk, and we are learning every day. And you see images, you compare what you were thinking before, and you'll be surprised a lot of times what's happening. especially under hemorrhage and especially PCVs, you are able to pick out small networks also, BVNs and all. I mean, it's all because of OCT. And me, I'm learning every day. I'm learning every day from OCTA, and I'm sure all of us. Initially, we thought diabetic retinopathy, what would OCTA show? But now various studies have shown that yes, OCTA has a place, and in future, being non-invasive, it may become a norm to follow up the patients of new vascularizations to see what's happening with the new vessels. Well, the house is open for everyone. If anyone wants to add anything.
Yes, and yeah, OCTA has a wonderful talk. He covered almost everything. So OCTA mainly in everyday practice, apart from studying the pathophysiology of various diseases, in, as he rightly said, in diabetic retinopathy, clearly differentiating between the neovascular tufts or the IRMA, and also in certain situations where we find choroidal neovascular membrane, like in Best disease, wherein the FFA is actually because of the hyper AF material, the FFA interpretation becomes difficult. So in those situations also, the vascular net that is very well characterized by OCTA. Also in situations like a CSR CNVM, in all those situations in a non-invasive way, OCTA gives a excellent characterization of the disease.
Well, that if no one has to add anything, that brings us to end of this wonderful webinar. And I thank all of you, starting from Dr. Varghese, Dr. Rana, Dr. Avdesh, and Dr. Ankur, for taking out time and presenting these wonderful talks. And to AIOS and the support team which is there behind us, hosting all these webinars. Thanks a lot and have a good night. And we'll meet soon. Good night.
Thank you, sir.
Thank
Right,
you.
Good night, sir.
sir.